All right, so this is chapter 9. This is skin, hair, and nails. So we're going to go over skin, hair, and nails. Shocker. All right, let's do it. So tissue integrity is a huge deal. Tissue integrity deals with the structure of the tissue itself and whether it's malleable or whether it's rough, whether it is lacerated or whether it has a wound. Tissue integrity is the reason for things going very well or things going very poorly. I always tell everyone the story. I had a stepsister growing up. Her name was Joey, and she died very young because she had spina bifida, and they didn't repair it back when she was born because she was a few years older than me. And she got a small wound because they went to change her brief. And when they did, they cut her a little bit. And because she was paraplegic and had been, paraplegic since she was born, she didn't feel it. So no one noticed it. She wasn't feeling any pain, wasn't having any issues. And by the time she even broke a fever to show that she, had an infection, it was already so deep that you could put your fist through it. And a lot of people go, how is that possible? And it's because of tissue integrity. See, paraplegic tissue reacts differently than tissue from someone that's moving around, right? Because the vasculature that we give our tissues when we move around forces the venous system to work, forces the arterial system to work, forces those capillary areas to be pulled with good nutrients and good source. Versus tissue where it's never really been able to transmit a signal to that area, it's weaker. I want you to think of it as I'm charging my phone using a legitimate charger that is like an iPhone charger that goes specifically for the iPhone versus getting one at the gas station. So one is like a hotspot, hot quick fix charger. It charges everything up in 20 minutes. The other one, it takes forever, right? That's kind of how you need to look at the idea of tissue integrity, because some tissues get those transmissions and they are firing and roaring. Like me, I move with a purpose. So everything is getting exactly what it needs, exactly how it needs it, right? However, when someone is born paraplegic and they don't move that part of their body and they don't receive those signals, it goes into autopilot, if you will, right? So it just gives it what it needs in order to feed. But there's a lot of little caveats and areas where I would innervate where they wouldn't necessarily innervate and circulate, if that makes any sense. So that's how I need for you to look at it. So nutrition plays an important role, right? Protein-rich foods are what we continually talk about in the semester and next semester and the semester after, because high protein increases tissue integrity and tissue healing and things of that nature. Sleep sometimes has a lot to do with tissue integrity in terms of if you get your rest, you're able to heal compromised tissue issues, such as a wound. Such as a surgical scar or surgical laceration, right? So things of that nature. That's how I want you to think about this while we're talking about these things. Next slide. All right, so the largest organ in your body or on your body is your tissue, your skin. Produces vitamin D, keeps heat and cold tolerated like it needs to be, protects the body from invasion, keeps all of your innards in and all of your outers out, so you sweat and your sebaceous glands are working. Nails, hair is included in this as well. Any accessory structures to the tissue as well. So yeah, let's look at the diagram in the next slide and kind of get an idea of what the tissue looks like as part of the continual introduction to hair, skin, and nails. All right, I'm going to use my little pointer. Little pointer, buddy. Are we here? Nope. There we go. Yay. So, all right, hair shaft, cool. Pore, yep, got it. Let's see, epidermis, and then we've got our dermis is down into this area, and then we have our subcutaneous layer, which is our fatty tissues, okay? So, a couple of these things that I'm going to need for you to notice is the word stratum corneum, okay? Because sometimes you'll see that word again, so I would look it up. I would also look up, I would look up epidermis, dermis, and subcutaneous layer, and here's why. I need for you to know what the epidermis is, I need for you to know what the dermis is, and I need for you to know what the subcutaneous layers are, how deep it goes, all right? And I also need for you to be able to stage an ulcer for me and let me know which layer it innervates. Ooh, that's a lot. Yep. So let me say that one more time a little bit slower. I need for you to know epidermis, dermis, subcutaneous layer. I'll give you a hint. If the word epi is in there, epi means above the other layers. Got it? Dermis is just skin. Sub means lower, right? So I need for you to know subcutaneous layer is lower than the other ones, right? Just like epidermis is above the others. And I need for you to know if it's a stage 2, a stage 3, a stage 4, unstageable. Where are we hitting in this hot zone? What does that look like? So these are how I want you to take your notes. All right, next slide. Yeah, and here we go again. So the anatomy and layers of skin composed of 3 functional layers. We got the epidermis, the dermis, and subcutaneous layer, or what they call the hypodermis. Please know that as well. So again, with these slides, we're taking you down a road to where at the end of the road, you're going to be a nurse. So when people say, I don't have any notes, we don't get any notes from my instructor, and I'm an academic coach, so I hear it a lot, right? Like I hear, so-and-so doesn't give us guided lectures, such and such doesn't do this. I only have this resource. Honey, you have the resource you need for your exam right here. These are the slides. This is the blueprint of the concepts that are going to happen in your examination, or should be the blueprint for the concepts in your examination. Like our test is going to be over hair, skin, and nails. Our test is going to be over neurology. These are the concepts we're talking about during this time period, because this is what we need to understand. So whenever you say that you don't understand how to study, this is where we start. So far, I've gotten 3 or 4 slides. I'm on slide number 5. And of the 5 slides, we have literally talked about the whole entire idea of skin. And now we're breaking it down into the manifolds and pieces and parts, the epidermis, the dermis, and subcutaneous layer. So this is where I would start doing my notes. So I hope that helps you complete an outline for yourself so that you know how to study for these. Okay, let's go to the next slide. And here we are further breaking it down. So the epidermis, outermost layer, stratified squamous epithelium. Stratified squamous epithelium are going to be indicators to let you know that you were in the outermost layer or the epidermis. So I would know that. It's avascular. There's no vascular system, okay? So if I don't have a good vascular system, a couple of things happen. Number 1, I don't get a lot of nutrient, right? So it's just kind of there as a protective layer, which is what it is. It's thinner. That much is obvious in the diagram we looked at earlier, right? So it's going to have a different type of function. And if it gets cut, it will heal. But the nutrients that it's going to have that are provided are going to be the tissues up underneath that area. Okay. So super important we understand these concepts of it being avascular. The deepest layer, we saw that earlier. I don't need for you to know specifically about it, but just know that it has a rich blood supply of the dermis that's right next there, okay? So basically it drinks from the bottom of the well, that tissue does. Look at this, site of active cell generation. That's a big deal. If we generate cells, if we generate new cells, what do we keep doing? Well, we're kicking out the old cells and we're bringing new skin to the surface. So that's perfect. Does everything we want it to do. It goes through the process of keratinization, which is something that you need to know. So I'll go to the next slide. All right. Outermost aspect of the epidermis, stratum corneum, you're going to need to know that, yeah. Composed of 30 dead layers. Process takes about 30 days total. Things continually get sloughed off. Things are continually coming in new and going through that process. Melanocytes secrete melanin, provides pigment. Melanin. All these fights and all these wars and all this hate because of melanin. That's it. Because of a byproduct. Just think about that for a second. We're only 40 seconds into the slide. All of the hate, worldwide, I'm not even talking about in the States, all the hate, all of the disgust, all of the wars, all of the people lost. Why? Because of melanin. One of the many reasons. But one of the bigger reasons that we're still talking about after all of this time, and it's so aggravating and stressful, but it's so necessary. All of this time because of melanin. Think about that when you judge somebody. Think about that when you look at somebody and think whatever it is that you're thinking in that moment, that microaggression that you have. Think about it and then get angry about it. And then think about why you have it. Think about at what moment did you develop that thought process, and then change it. Change it for the better. People don't need to die over melanin. People don't need to hate over melanin. We are all perfectly imperfect. We are all wonderfully made. And we are all a part of one another. So to hurt you is to hurt yourself. To hurt you is to hurt me. Right? So to hurt another piece of you and a part of you is to hurt yourself also. Think about that. All right, next slide. Okay, so the anatomy of the dermis. The dermis is made up of highly vascular connective tissue, all right? So it also deals with sensory nerve fibers. It also deals with heat and cold through dilation and constriction of those vessels. So if it's hot outside than normal and you need to cool down, the blood vessels are dilated so that more blood flows near at the surface of your body to allow that heat to be lost in the air, okay? And if you're cold, it constricts to maintain that internal temperature to the core. Does that make sense? So that's kind of how I want you to look at these things, right? Also, sensory nerve fibers for touch, pain, temperature. We just talked about that. Arrangement of connective tissue enables the dermis to stretch and contract with body moving. Yeah, absolutely, right? Good connective tissue means skin won't rip. If a 96-year-old is trying to bend and twist and move, they could get a skin tear. You got to be really careful about body mechanics and movement in a hospital setting up under a bunch of sheets when they're tiny and 96. We just know that because they're very brittle and their tissue's very brittle, right? Because it's been through many, many layers and many, many years, and the natural process of losing its vascularization due to aging, right? So these are how I want you to do your notes, and these are the things that I want you to have in your brain. All right, next slide. All right, so the hypodermis, or the subcutaneous tissue, isn't skin tissue. So it's a support structure for the skin tissue. All right, so think about adipose tissue. Go back to the lecture slide where it showed you the different layers. So adipose tissue, I want you to think of as it's a bunch of globules stuck together, right, to create an even larger piece of globule. But when you shake it, if you actually had real subcutaneous fat in your hands and just that layer, when you shake it, it wiggles like jello. I'm not even playing. So it's the support structure for those other areas, right? The dermis and the epidermis. So I want you to think about it, and I know that it feels squishy. Like it would feel squishy to walk over it or to walk over top of that adipose, because the adipose tissue feels like uh, really really you know tough jello to be any other way. I mean, you could. I don't know if you guys have felt ballistic silicone, but that's kind of what it feels like, right? That adipose tissue. So it helps retain heat, helps protective cushion, like we talked about. It helps hold and maintain caloric intake, or to hold on to calories, right? And again, it acts as a foundation for those upper layers of the actual tissue of the skin. All right, so appendages. Appendages are going to include hair, nails, glands such as exocrine and apocrine sweat glands and sebaceous glands. So here's how this works. Apocrine and exocrine are both types of sweat glands, yes. Exocrine glands are found all over the body, and it secretes a thin, watery sweat that cools the skin itself. Whereas apocrine are found in the armpits and the perineal areas, and they're attached to hair follicles. Okay. There is a thicker sweat in these areas, which is acted on by bacteria, which produces the sweat smell, right? Versus the rest of our body that doesn't do it so much. Okay. So that's the difference between exocrine and apocrine, just so you know. The structures are formed at the junction of the epidermis and the dermis, yeah. So I think that's it for this slide. Let's go to the next one. All right, so hair. Hair is formed from the epidermal cells in the dermis. We have a root, a shaft, a follicle. We have a papilla, which is a capillary loop. Melanocytes, obviously melanin provides color. And I think that's all we really need to talk about for this slide. All right, so epidermal cells that are hard plates of keratin, those are your nails, right? Nail plate, nail root. Adjacent to it is the parenchyma. Cuticle, or the cuticle of the epidermal tissue, right? That stratum corneum grows in the nail plate at the base. And I think that's all we need to know. Let's look at a diagram of it in the next slide. All right, here's all my pieces and parts. So just give yourself 30 seconds to review over it and just remember what you already remember and what you already know, and then move on. All right, so again, exocrine sweat glands, they regulate the body temperature. Remember, it has that fluid that comes out and cools the skin. So it's the most numerous, most widespread, its greatest concentration. Oh, what do you know? The 3 spots where we need to regulate heat and temperature from the most important parts, right? So if I have a person with a temperature of 102 and I'm giving him an ice bath, I'm sticking it in all these places. Also the under armpits and the groin, right? But again, this is why. This is where we produce such temperature regulation in these areas, and why we would produce that, because it's got the highest and greatest number of those exocrine sweat glands in those areas. All right, next slide. Now, unlike your exocrine sweat glands, the apocrine sweat glands are larger and deeper than exocrine. And why is that? Remember, they also carry the hair, okay? So found in the axillae, the nipples, the areoles, the genital regions, external ears, eyelids, yep. Secretes odorless fluid containing protein, carbohydrates, other substances in response to emotional stimuli. The decomposition of the apocrine sweat glands is why you get the smell, FYI. And let's go talk about sebaceous glands in the next slide. So let's talk about sebaceous glands, or sebum. Sebum excretes this lipid substance, or sebum, which keeps the skin and the hair from drying out because it's fat, okay? So basically, these areas keep things nice and oiled so that you can keep the hair follicle bathed in this this gland, right? So that the hair doesn't just break off. So makes sense. And then let's talk about, there's really nothing else we can talk about. Greatest distribution found around on the face and the scalp. I wonder if that's why, I'm going to have to look this up. I'm pretty sure that this is why people lose their hair. Because we're killing the cells. Oh, sorry, I'm thinking about chemo, guys. Let me think about this for a second and rationalize that in my brain. So the reason we truly lose our hair in chemo is because we probably, if I had to guess, and let's look it up and see if I'm right, I would say that the reason that we killed them is we chemically destroyed them in the process of chemo. So it does something to these glands that prevents your hair follicle from being able to hold on to that hair clearly. I'm just wondering if it dries up the sebaceous area and that excretory like lipid protein, if that's what it kills, and then the hair literally breaks off because it's so dry. And that's why you really truly lose all of your hair. I'm going to look that up. That's interesting because it would make sense, right? Common sense would take you there. So we'll see. But yeah, I think that's all we need to know for this slide. We can move on to the next. All right, so presenting your health status, we need to ask questions that are going to be relatable to the hair, skin, and nails that are going to let us know if this person has a problem. So case in point, if I say, do you have any chronic illnesses? And they go, yeah, I have iron deficiency anemia, right? I'm going to know to look at their nails and inspect them because I would expect them to be pretty weak, pretty brittle, right? Because that's just what comes along with the territory of iron deficiency anemia. I'm going to assume that they bruise easy, right? I'm going to assume that their skin is going to be a little bit paler or even a greenish tone, right? Because again, this is the disease process. So when you're looking through these questions, I want you to keep these things in mind so that you can go, okay, well, I know if I ask this versus ask this, this is going to narrow it down to this. All right. So this is what the slide is trying to let you know. And the next slide is probably going to do the same. And again, have you ever had problems with your skin, such as a disease, infection of the skin of the nails, or trauma involving the skin? This is an oddly specific question to take us to an oddly specific area of the deduction process and understanding what the disease process is a patient truly has. All right, next slide. All right, here are some diseases of the skin. Note that itching is most commonly reported symptom of a skin disease. Okay, so we're going to do onset, location, duration, characteristics. We're starting to spell old cart, friends. This is what this is old cart. So let's go into the next slide and we will probably continue on talking about itching. Yeah, here we are. So when did the itching first start? Did it start suddenly or over time? Where did it start? Has it spread? Things of that nature. Now for rashes, we need to ask things a little bit differently. We need to ask things like, is it flat? Is it raised? Right? So when did the rash start? Is it flat? Is it raised? Those are very important points of contingency because it's going to let us know if this truly is a rash or if this is something different. And we're asking the questions related to pain that we need to get into. When did the pain start? Where is it located? Guys, look at these questions. I know it sounds super stupid, but these come back on your tests all the time, right? Things like, find a definitive question related to old cart, related to an area of the skin, and you're going to need to know when did the pain start is going to be your onset, right? So these are why they give you these slides, and this is why I tell you to describe pain or discomfort, because a lot of times the question on these tests will say, find a statement by the nurse that fits this type of statement, right? So just pay attention. Next slide. And again, when we're talking about things like lesions, we need to know things differently for lesions. So we need to know the color, the shape, the texture, tenderness, bleeding, itching. Is there depth to it? Does it tunnel? Things of that nature, okay? Do we have any moles that do any strange things? Do we have any lesions that do any strange things, right? So yeah, keep those things in mind. And again, changes in color of the skin can indicate many things. It can indicate jaundice. It can indicate iron deficiency anemia. It can indicate cancer cells. It can indicate a billion things. But we need to know, because if we see that someone's getting yellow kind of everywhere, I need to be looking at a bile duct issue. I need to be looking at liver. Pancreatitis can also do it. It's not just liver. It's mostly liver, but it can move on to other things depending on where there's an occlusion or whether we're just, holding in too much bilirubin. Big difference in the two, right? Have you gotten thinner skin? Is it fragile? Is there excessive dryness? Okay, well, you might have a problem. You might have a deficiency problem. Excessive dryness, fragile, thinning skin. I think of people who don't get enough protein in their diet and don't get enough nutrients to have, those healthy tissues. So then I think, all right, what's wrong with them? What do we need to do to get them straightened out immediately? What deficiencies can we have? We can have many deficiencies. We can have an autoimmune disorder. We can have iron deficiency anemia. We can have a B12 deficiency. We could have a riboflavin deficiency. Let's see. We could have exacerbation of lupus. I mean, it could be a lot of things. We can go into 15 different directions, but we need to know, because this is how we play the rule-out game. Next slide. All right, wounds. I'm weird about wounds. Everyone's weird about something. I'm weird about wounds. Obviously, with having a stepsister who died in her 30s, that was easily preventable, it makes me very angry, right, that we don't pay attention to wounds enough, because people who have compromised tissue integrity due to paraplegia, their tissue breaks off so much easier and so fast. Like, I've seen a stage 2 go to a stage 4 overnight. I know that sounds nuts. I've seen it happen in just a couple of hours. All right, because if you put somebody like at the right spot at the right time, and then you don't move them, and they get 6 hours on a bar and don't realize there's a bar up under them, it's going to make a 2 go to a 4 very fast. So you have to constantly keep moving these people. I know you got to get up every 2 hours. I know you got a stack of 6 patients. I know that we're understaffed and we're 3 million nurses in debt. That's why I'm trying to bring you guys here, right? So I can get you out into the open and close that gap a little bit more, so that our patients have better service and better quality, and my nurses aren't burned out and miserable and angry, right? I don't like patients yelling at us because we didn't give them the service that they felt, because I have to go spread myself 6 patients thin, right? I get it. But this is how we help out everybody. And this is how we start. We have to get up and make sure that these wounds are checked on every day, every shift, that we are turning these patients like we're supposed to every 2 hours if they can't turn themselves. And I mean, not like just, okay, I'm going to let you shift your weight to the left just a little bit. Okay, great. No. I mean, we need to help the blood flow to these areas. We need to do, a passive way of moving their body and grinding their gears for them, because they can't, right? It hurts. It's painful to have a constricture. It hurts. Have you guys ever tried to touch your toes, and you're old now? You're not young and in gym in middle school, so then you go to bend down to touch your toes like you used to? I used to be able to put my palms of my hands all the way flat on the ground, bending down, toes touching, perfect, right? I went and did that the other day. I was like, I'm sure I could still do that. Dude, I physically couldn't bend any farther. I thought the back of my tendons and my legs were going to snap. That's like that, only the contractures are 20 times worse. So please keep these things in mind. We have to do right by people. So do right by them. Next slide. Now we're asking about hair, and we're asking about changes. All right, cool. Stress, fever, illness. Okay, we're trying to figure out, if I'm asking stress, fever, and illness, I'm asking, is there something that they're doing that's making them sick, that's causing these problems? Is it a history of an illness that's a problem? Is it something that could be stressing them out, which is causing them to have a dump of cortisol and then mess up their hair? Like, what's the deal here? So we're just kind of hitting every angle, and this is what I call shooting bullets in a field to see, and what rabbit falls. type of a deal. We're just throwing things out in the air, hoping for a Hail Mary. Next slide. And here we're talking about nails doing the same thing. So just look over this for a couple of seconds and move on to the next slide. All right, so when we're talking about examinations, we have to inspect the skin for color, for uniformity of color. We need to make sure that if people, have vitiligo, we're documenting that, not that they have a diagnosis of vitiligo, because that requires a doctor and that would be found in your history. But if this is something they haven't been diagnosed with, you can't say patient has a history of. You'd have to say, patches of white and patches of dark tissue ranging from, this shade to this shade, found on patient throughout body, right? Or it could be something like a cafe au lait spot, right? So you'll just have to see what that looks like and document it accordingly. Whitish pink to olive tones to deep brown. Yeah, perfect. That's how I would describe it. Sun exposed skin is darker. Really? I feel like that didn't need to be a bullet point. Well, it doesn't matter. Bygones. So yeah, look at color, pigmentation, things of that nature. And we can move to the next slide. Again, no any tattoos, any moles, freckles, patches, things of that nature. Now, I want you to pay attention to these, because when we're talking about inspecting the skin, I want you to look over them. I know that you know how to inspect the skin, but remember, Professor Rickert is giving us a very, very big end of the semester full examination that we have to do on a patient that's a head to toe. So this is an opportunity, excuse me, to learn those pieces and parts so that we're prepared. So while you're on these slides, I want you to be picturing yourself saying these things. So when I get up to my patient and Professor Rickert's staring over at me and I'm feeling a little intimidated, I remember palpate the skin for texture. So I say, yeah, I'm looking at the skin, I'm looking at it for temperature, for texture, moisture, pigmentation, I'm looking for lesions, I'm looking for moles, right? Does that make sense? So this is how I want you to look at these slides. I don't want you to just blow through them and be like, it's just a whole bunch of nonsense and useless. No, if it were important to me and it's in the slides, then it's important for a reason. So this is how I need for you to go over this in your head, this is how you would prepare yourself to do these inspections. So he's cool with you looking at the skin and going, hey, really quick, I'm noting the texture of the skin, I'm noting intention to find any lesions on the skin, to find any moles, discoloration, disfiguring, qualities, temperature, moisture, right? And he'll go, okay, cool. And then you got that part done. So do it that way. And then go to the next slide and we'll talk about hair. So again, examining hair, we're checking to see if it's soft, to see if it's brittle, to see if it's thick, to see if it's thin, to see if it breaks off, to see if it's kinky and curly, to see if there are any bugs in it. Like, we're just doing a whole bunch of stuff with the hair as well. So again, when you're going through this and we only have so many minutes for you to actually do your examination, these are the things I want you to say, right? Like, hey, real quick, I'm checking the skin, I'm checking the hair and doing this, and this. I'm looking for this and this. And then he'll be like, all right, cool, move on. So now let's look at nails next. All right, so here we are looking at shape, contour, color, consistency, if your fingers are clubbed, things of that nature. If we have any grooves or divots that shouldn't be there, any pits or ridges, things of that nature. And we'll look at the next slide about infants and children. All right, so we want to look at rashes when we're talking about kids. It could be just a regular diaper rash. It could be a diaper rash associated with an allergen. It could be something like erythema toxicum, right? Which is where you have that toxic swelling. That's really nasty stuff. It could be a derivative of a heat rash, things of that nature. So that's what we have to pay close attention to when we're talking about babies. And let's talk about adolescence next. What do you think of when you think of adolescence? I think of acne, pizza faces. So that's what we normally talk about when we talk about adolescence. Lesions are usually not painful unless it is acne vulgaris. And I've seen some pretty serious acne vulgaris. I mean, some ridiculously serious acne vulgaris that ain't no joke. So when you get mad because you have a pimple and you're 30 years old and you're like, oh my God, I have a pimple, like be super solidly grateful that that's all you ever had to deal with in adolescence, because there were some people that had some really, really bad acne and still have it to this day and will never ever get away with it. So make sure if you're like complaining about one little acne mark that no one's paying attention to anyways, like you don't do it in front of somebody that really has true acne vulgaris, because it'll make them a little angry, and I get that. So just make sure when we're dealing with adolescents, if you have an adolescent patient that he presents to you, make sure that you also say, noting variations of acne vulgaris or checking for acne, things of that nature. Next slide. All right, so older adults, skin is going to make a significant change. We're going to start seeing those old people spots, or what they call liver spots, that it's in the skin. We're going to see common lesions, common scars over, time. We're going to see thinner tissues, more fragile tissues, things of that nature. Next slide. All right, so hemiplegia, paraplegia, quadriplegia. All right. So all these guys are at increased risk, an incredibly increased risk for skin breakdown. All right. So make sure that you understand the concept of the why behind it. Make sure that we understand we have to turn them often, at least every 2 hours. I said at least. If they're able to shift their weight, they need to be shifting their weight. If they can't, we need to be shifting it for them. And that's all I'm going to say about that. Because you want to make a person angry, let me find out that you have done this to somebody or caused one of these on somebody, and I will get stupid fast, as I should. Don't let this happen to somebody, please. Don't let it happen. It's not okay. It's a painful way to die, and sometimes it takes months. It's just a slow burn. So I want you to think about that. Think about that when you don't want to get up. Because you're going to have days where you're not going to want to get up. And you're going to tell yourself in your brain, man, that patient doesn't even take care of themselves. Why should I? Right? Like, I'm just exhausted. And they've been yelling at me all day because I haven't done something right. But really, it's just a projection of the fact that they can't move. And that they're here and stuck in the hospital with me, where I get paid to pretend to care. And I'm not giving them the amount of attention they really deserve, if I'm honest. So those things go through your head as a nurse. Those things go through your head as a patient. And I know that because I'm 100% raw dog with you guys. I'm never going to lie to you. I got no reason to, especially not with this. There's so much PTSD that you're going to get out of this job. And I'm not even playing, like, I'm not saying like bully PTSD, because trust me, I know that that's super serious to some people. But grossly and largely in part, people say they have PTSD, and it's not true. It's not the same. Trust me. I know the difference between PTSD and PTSD through the eyes of most people and their experiences, and 80% of them got it wrong. There are some that genuinely got it right. But I need for you to know that you're never going to know PTSD, or what you think is quote-unquote bunny ears, paraphrasing PTSD. You're going to finally figure out what that truly means. And when you hear someone say they got PTSD from test anxiety or from bullying, a part of you is going to want to just really, really get angry with them and do just angry things. Because when you truly get it, and you'll get it, you'll know. It's one of the triggers, right? Is people downgrading that process. It's a big problem. So in the process of you guys getting this, I need to prepare you. And that's eyes wide shut sometimes, so I'm sorry. So these thoughts are going to go through your brain, because these thoughts have gone through my brain and every other nurse's brain. I'm just the one willing to say it. Because every nurse is going to talk a big game about how we all need to be great nurses. But until you truly are at the bedside, until you are truly on a unit that is a hard unit, like a med-surg unit. People make fun of med-surg because it's the easy people. It is the easy people. They're easy and they're entitled sometimes, and they get mad at the cafeteria because they don't cook their eggs right? and they act like divas, and they treat their nurses really nasty, and their nurses get really burned out really fast. And I know that because I was a traveler for 7 years. So sometimes I'd have to be on med-surg units, and I noticed that that's what they do on med-surg units. And some of you guys are going to have progressive care units where you guys are technically getting an ICU patient, but they're not calling it an ICU patient. And the reason that the doctor wrote that the patient's doing this versus this and is getting better isn't because he's truly getting better, because you all know he's getting worse. It's because you can't afford the staffing to not have them on a progressive care unit because you got enough nurses on that unit, so you got to lie to do it, right? Oh, you don't think that happens? Oh, friends, you're going to play a whole nother game of raw dog martial law, and it's called healthcare. I'm talking martial law. If you don't know what martial law is, look it up. You need to know. Because a lot of medicine is martial law. A lot of medicine is, I know how to play the system, and we're going to play the system like I play it because I'm the doctor or I'm the nurse, and I got to do the right thing for the right person because insurance isn't going to cover it, so I have to do it this way so that it can, right? Healthcare people, nurses and doctors, they're like the Robin Hoods of the world, right? They rob from the rich and they steal from the poor, or they steal for the poor. That's exactly what we do. If I know an insurance premium isn't going to get covered because I call it this disease process versus this disease process, and it's nearly the same disease process, which one do you think I'm going to do? I'm going to give it that QR code that it needs to get that insurance approved, right? So that that person can take that medicine and not have to pay $400 a month. So when you're telling a doctor that they're stupid, or when you're thinking a doctor isn't doing what they're supposed to do because you're a nurse and you've never been a doctor for a day in your life, and until you are, you won't get it, don't say what you want to say when they walk away from the room because you're too scared to say it in front of their face. Don't do it. Don't be that guy, because unless you've lived a day in their world, you can't. All right? And you're going to learn that these are both good things and bad things that we have to deal with sometimes. All right? Because that's really the world of healthcare. So, make sure that you're taking care of people. Make sure that you are doing what you need to do. I know I got off into a tangent about how this is really going to go for us and how scary it's going to be, but there's a lot of great in it too. I wouldn't be here if I weren't happy. This is the only thing I could ever imagine myself doing, right? Because I live in a world where the rules are my own, and it's kind of amazing. And you get to help people, and you get to protect humanity when there's an apocalypse. Didn't see that one coming. Whoops. So, yeah, it's a wild ride, but you need to protect yourselves, and part of me protecting you is letting you know what you're walking into. So, 6 minutes later, there's your slide, and let's move on to the next one. All right, so really quick for skin, we need to talk about the findings that are going to be normal findings and other findings that would be considered abnormal. You're going to need to point those out when you're doing this examination or this head-to-toe assessment. That's your final examination for lab. So make sure that you're pointing those out if you see things. If you see a big area, don't say big area. Say $50 size, quarter size, dime size. Give me actual measurements, right? Because I need for you to physically measure it. If you don't measure those things, you will fail. You have to measure it. Okay? Length, width, depth. Length, width, depth. Okay? Next slide. All right. This slide, you're just going to need to know it. How about that? Stage 1, prolonged redness with unbroken skin. Blanchable. Non-blanchable. You need to know the difference between blanchable and non-blanchable. I'm not even going to tell you. I'm going to make you look it up. I'm also going to make you look up in a stage 1, are we blanchable or are we no longer blanchable? Those are your 2 homework assignments. That's going to get you some points on your exam. Stage 1, stage 2, stage 3, stage 4. I need for you to know how deep into the tissue, like I told you earlier, this is going to happen. I need for you to know what stage. I need for you to know what's going on with the skin and how deep. Cool? And then tell me what unstageable means. Tell me what unstageable means. So if I see eschar or sloth at all, that is an unstageable, even if a little bit. And I need for you to look up the difference between eschar and sloth. Cool? All right, next slide. All right, so hyperkeratosis, I need for you to look that up. Dermatitis, I need for you to know atopic versus contact. I need for you to know what it does versus seborrheic in chronic infections. I need for you to tell me what it looks like. I need for you to tell me what causes it. Cool? Next slide. All right, psoriasis. I need for you to tell me when it starts. I need for you to tell me what it looks like. I need for you to tell me where it's at. I need for you to tell me if it's something that we can do to fix that. What medication do we fix it with? And then pityriasis rosea, we need to know those two contingency points as well. And next slide. Again, I need for you to know the difference between warts and herpes simplex and herpes varicella and herpes zoster. Because I will say these things. Like I will literally say, I'm terrified of herpes zoster. And people are like, you're terrified of chickenpox? And I'm like, that's not what we're talking about. Herpes zoster is shingles. Okay? Herpes varicella is chickenpox. Big difference. Big difference. I need for you to know. Because we will say herpes zoster to one another and know that it's shingles. We're not going to call it shingles. It's not how docs talk to nurses and how nurses talk to docs. That's what incompetent nurses and incompetent docs do. They say shingles. Or we say it to our patients because they don't know, right? But when we're talking in close quarters, it's just understood that we're going to use the big boy talk or the big doc talk. And we use the big doc words when we do that. And when we're with our patients, we use the little boy words like the shingles. Okay? So you'll need to know what those things mean, what it physically looks like. All right, next slide. All right, tinea infections. Lesions caused by fungal infection. All right, so I need for you to know which one's which. And then candidias. I need for you to know what layers and what kind of infections when we have candidias or candidiasis, however you want to pronounce it. Yeah, so know those as well. Next slide. All right, so lesions caused by bacterial infections. I need for you to know bacterial infections are cellulitis, impetigo, folliculitis, and furnicles. I need for you to know that a furnicle is an abscess versus a boil, or it is a boil versus hair follicles and an ingrown hair. Okay? So that's what I need for you to know for this. Next slide. When you're looking through these terms that I'm giving you, and you've never seen it before, I need for you to Google it. I want you to Google image it so you can see it. Okay? So like scabies. If I've never seen scabies before, I would type in scabies. And I would spend 2.5 minutes learning about scabies. Where does it burrow? Where is it at? What does the lesion look like? It looks like striated areas. It's very different than Lyme disease, which is a bullseye. And it's a very hallmark bullseye rash, right? Versus spider bites, which is like a brown recluse, which means half of your arm's falling off. All right? Don't believe me, look it up. It's a necrotizing venom. So give it a go. You got to look them up because you're going to have patients like this. So you might as well get used to it. And let's do the next slide. All right, so for this slide, I want you to know what type of carcinoma, where is it at, is it serious, and know your definitions. And again, I would look things up if I didn't know it, like squamous cell versus basal cell carcinoma. You need to know what these things look like. You need to be able to recognize them on your patients. Next slide. All right, so abused people have 3 common types of lesions. Bruises, bites, and burns. The 3 Bs. both human and insect bites sometimes, depending on what's going on. So keep in mind when you get people like this, you got to be really careful because they're going to be very skittish. So you have to ask questions and you have to ask them smart. Okay? You can't be very abrasive with these people. You can't be very jokey. Like I'm usually a pretty funny person, or at least I try to be a pretty funny person. I will never be more serious in my life than when I get a patient like this. So I would encourage you to do the same. Next slide. All right, so pediculosis, not my favorite. Make sure that you know what they're called. Alopecia, make sure you know what that is. Look it up if you don't. And the same for all of the above definitions, because those are going to come back again on examinations and NCLEX and NextGen and standardized testing as well. And again, when we're talking about these different conditions, just look them up is the best way that I can do it, because I can talk to you until I'm blue in the face about them, but until you actually see it for yourself, it's really not going to help you at all. So I would look it up. We've got a couple of questions we're going to go over, and a case study that we're going to go over. I'm debating on whether I'm going to give my answers in lecture or whether I'm going to give them in class time so that we can go over them together. So I don't know. I'll see. Let me think about it. Let's just go to the next slide for now. All right, so I've just decided that I'm going to play you these slides, and you are going to give me something for some solid extra credit. How about that? So I'll know who's listening to my lecture and who's not. And I'll also know if you told your friend to listen to the lecture because it's in there. So make sure that you don't do that either, right? So I'm going to make this an opportunity for some extra credit, and I want you to find these answers for me and present them to me at the next lecture, and I will give you extra credit points if you are correct. Cool? I will explain that later. So for right now, as the nurse performs a respiratory assessment, he notes a mole on the patient's back over the right scapula. What is most important for the nurse to ask the patient? And then we answer our question. So next slide. Here's another familiar question. A pustule is noted over the maxilla of the patient. Which of the following illustrates a pustule? So let's do the same for the case study. Silas is a 2-year-old male child who attends daycare. He has 8 siblings at his home. Wow. All of his immunizations are up to date. He has a history of strep throat and RSV. His family activity is, or his favorite activity is block stacking. His mother reports that he is generally happy baby who is starting to become potty trained. And we know with our subjective data, complains of painful rash on right calf that is spreading to lower legs. Mother says the rash has been there for more than a week. Mother admits to trying oatmeal baths to stop the pain, but it's not stopped. Objective data, temp is 96.4, pulse is 71, respir's 14. Right calf has dime size honeycrust sore. That's interesting. Right calf has become increasingly more irritated over the past week. All right, so here are our questions for our case study that I want you to answer. And you don't have to get into grave detail. It doesn't need to be that ridiculous, right? Just a simple sentence is fine. And then another case study. Sydney is a 4-year-old male child who attends preschool. He has 5 siblings at home. All of these immunizations are up to date. He has a history of otitis media and RSV. His family activity is sandbox play. He reports play most of the day in sandboxes at school. All right, subjective data, complains of itching, circular rash behind his left ear. Mother says rash has been there for 4 days. Mother admits to trying Vaseline to stop the itching, but says it's made it worse. Vital is 97.2, temp, pulse is 68, respir 16. Left ear rash, classic ringworm shape with scaly appearance that spreads to his hairline, no drainage. The rash is quarter-sized. Interesting. All right, cool. And here are the questions that I want you to answer for that. And that concludes this lecture. We did it in 54 minutes. It's not bad.